We're going to go through some issues related to opportunistic infections in newly diagnosed HIV-positive children. So this is a child. He's a 1-year-old male. He's HIV exposed. At the time, we were doing a 6-week HIV PCR, which was negative, and they had no further testing until this time point. So he had missed all his other testing time points along the period. There were no antenatal problems, and the mother had breastfed up to 8 months, and they received all the immunizations. The mother was HIV positive, was diagnosed in pregnancy, and started on our standard first-line treatment. The viral load at that stage was unknown. The father was 22 years old, and he was HIV negative based on a verbal report. He was employed, and he was supporting the family. And the grandmother was a primary caregiver until about 6 months ago, when the mother took over. So he presents with a loss of appetite and weight, with a chronic cough of more than 2 weeks. On clinical assessment, he's got severe malnutrition, which is his weight for height. Z-score is less than -3 Z-scores, and he's assessed as having a low respiratory tract infection. So his Xray is this. He's had an induced sputum, and the gene expert is negative, and the AFP is negative. The culture at this stage is positive. The ESR is spectacularly high. There's no identifiable contact, and the HIV PCR at this stage has come back as positive. Okay,
Can I just ask, Mo, why did you do the ESR?
Yeah, so there's some people who swear by the ESR, and there's some people who don't swear by ESR. So so there's always a battle between the benefit of ESR, and the difficulty with TB is there's some people who really, really love ESRs. So it's one of those things that get done where you have generational or institutional knowledge that's within the institution. So it's a newly diagnosed HIV-positive patient. He's got a pneumonia. He's got a raised ESR. He's got these chest X-ray findings, and his gene expert is negative. And this is his chest X-ray. So, Henrietta, so how would you manage this child in your setting? So he's newly diagnosed HIV-positive with these clinical findings.
Gene expert is negative, and the culture is pending. I think this is a TB, unless it is proven something else. But I think that's the first thing I would say. And so I would also would like to have some more information about his HIV status in the like CD4 also,
okay.
And CD4, yeah, and the HIV PCR is positive. So I probably would start on TB medication.
Okay. So would you do any additional testing in addition to what's been done before starting TB treatment? So would you empirically start TB treatment?
Yes, I would like to have a stool for TB diagnostics, and if I don't know, maybe you have to be aware of if this pulmonary TB or maybe interbronchial TB. So maybe you have to do a CT scan as well. But maybe in this setting it's not possible. But in our setting it's possible.
Okay. Grace?
So in a Zimbabwean setting, we would be able to do a gastric aspirate to obtain kind of potentially a higher yield of bacilli there. To go on to do a CT scan, it would be possible but costly, and the family may not be able to afford that. So given his loss of weight, cough, etc., it would be TB on a clinical diagnosis, and we would start him on TB treatment.
Okay. So essentially, as an empirical treatment, you'll start them on the first line TB treatment based on the evidence that you have. So what we did was we started him on 4-drug TB treatment, and because of those mediastinal nodes, we added steroids. During that course, he had quite a stormy course. We had a Klebsiella pneumonia UTI, and he was 2 weeks later. We had started him on our first-line antiretroviral treatment, which was abacavir, lamivudine, and lopinavir ritonavir with ritonavir super boosting. During his course, he did well in hospital. He gained weight, but the father was not available at any stage during that admission. So after 1 month, the patient clinically improved, and again, we hadn't seen the father up to the stage. The 4-drug TB treatment was continued, and the steroids were weaned. So 2 months after that, the TB treatment was changed to the continuation phase, and the antiretroviral treatment was continued, and the patient was down referred to a lower level facility to continue their medication. So this is now 18 months later, so at 18 months, and that's 6 months after being on antiretroviral treatment and being on anti-TB treatment, he represents to us with loss of appetite, loss of weight, and a chronic cough. At this stage, he has a mild respiratory distress with decreased air entry on the left side on auscultation. And there's a history that the child is now has moved to live with the grandmother, and the mother's not entirely sure whether the treatment has been given as appropriately in terms of both the compliance to the TB treatment and the antiretroviral treatment. So on assessment, we have this kid who is now on 6 months of TB treatment, 6 months of antiretroviral treatment, who he represents with, he's moved from a severely malnourished child to a moderately malnourished child, which is not entirely adequate, but he's got this persistent left-sided pneumonia. So what would be your differential for this child? So we haven't, so Jason.
It seems like there's a respiratory focus. And so we would have to go back to our original diagnosis of TB and ask, was that the right diagnosis, or could it be something else? Unlikely in this setting, but you would think about other potential opportunistic infections, fungal disease, other bacteria, other things like nocardia. You could ask, could this be tuberculosis but a drug-resistant version, or potentially when the 4-drug therapy was reduced to 2-drug therapy, you lost some effective agents on the top of some baseline resistance. And then the third option, I think, would be an iris event, where you gave steroids for the first couple of months, and now we didn't see the baseline CD4 count, but if the baseline CD4 count was extremely low, then this child would be at risk for iris. 6 months is a bit far out in terms of presentation, but it has been reported. And then, I think those would be my main ones. And atypical mycobacteria, I guess I forgot to mention, could have had some partial response to RIPE, and with the steroids on top of that.
Okay, Tavichi, what would you add to that?
Yeah, I agree with Jason. And recurrent TB from multi-drug resistant because poor adherence to anti-TB, or recurrent TB with complication like pruritus, pleural effusion, and maybe massive lymphadenopathy, and also iris.
Okay, and malignancy?
Malignancy is another another differential diagnosis, such as non-Hodgkin lymphoma that caused the mediastinal mass. I'm not sure.
Okay, so that's one of the issues. Is sometimes we have to be forced to rush into starting TB treatment before we have the full information available, and often after the fact, we trying to now clutch back some information to try to make a diagnosis in retrospect. So how do you further investigate this patient in your setting? So if you had, in Europe?
I think I would like to have more imaging, like a CT scan, and look what's happening in the thorax.
Okay, Grace,
So
anything else you Would you want another ESR?
No, definitely not. I think also to go back, so the grandmother is now the caregiver. Has anyone asked about her kind of, is she coughing? Is, you know, I know you've mentioned that the parents are TB negative, but what about the grandmother? And so could she potentially have a drug-resistant TB that has been transmitted to the...
Okay, and then the other thing that we haven't mentioned is that this could all be non-compliance to her treatment, and this is just treatment failure from both her TB treatment and her antiretroviral treatment. And certainly you'd want a CD4 count and a viral load to make that differentiation between a response and non-response to treatment. So we did do an ESR, and it was now more spectacularly high. So it was more than 240. So he had a viral load that was undetectable. The CD4 count, we hadn't had a baseline CD4 count, but this is a reasonable CD4 count for this severity of illness that the patient had presented. He had a repeat sputum workup, which included a repeat induced sputum, a stool for AFP, and gene expert, which were all negative. We went back and checked for his TB culture results from the previous admission, and the culture was negative. And the father had pitched up on the second admission, and his both mother and father's Xray were negative, were normal. And we had done a test on the father who was positive and referred for treatment. So this was his Xray. So essentially, I won't ask you to comment, but just to show that there's decreased volume loss on the left with this quite widened mediastinum. So there's this extensive consolidation on the left, and the consideration was one of endobronchial TB with TB lymphadenitis was compressing the airway, but this could often be a mediastinal lymph node from a malignant or a non-TB infection as well. So how would you go from here, Jason?
I would probably want to go ahead, as Henriette had, with a CT scan to have a bit more information, particularly around airway compression and the acuity of the situation. In our setting, we always want a tissue diagnosis or sampling, and so I would ask our respirologist to see him with a view to bronchoscopy if they're brave enough. Usually we get the fight back. They're not sick enough or they're too sick. So hopefully they're in the sweet spot. And I would want to have a bit more information before going any further.
So I'm glad to know that we're not the only one who has problems getting the cardiothoracics to do the same things to our kids.
Yeah. And I liked Grace's comment about the grandmother, so I'd get more history about the grandmother, whether she's a nurse in a hospital in KwaZulu-Natal or something like that.
That's not the curveball I was going to put in, but Taviti, so do you think this is iris?
Yeah. Yeah. But you just gave CD4 well load.
So he had a CT scan done, and essentially what it showed was there's extensive lymph nodes around that left main bronchus, which is essentially surrounding that bronchus, causing airway compression and essentially blocking off that airway with collapse of that left lobe. So he had these multiple necrotic lymph nodes with calcification. He had essentially lymph nodes throughout that mediastinum. So how would you manage this child further? So we've Henriette?
Yeah, I think I go to my colleague pulmonologist to help me in this case.
It's always a good idea.
Yeah. And maybe bronchoscopy, if it's possible, to look whether it is also endobronchial problem like edema, so you can do something like an intervention. But I'm not sure on this. Okay. Probably you have more experience in this.
Great, from your setting. So what would you do? You have a child now who's 6 months on TB treatment and antiretroviral treatment. He's had some immunological, you assume some immunological response, but certainly he has got virological response to treatment, and now he's clinically deteriorating with this chest X-ray finding.
So interesting that, yes, he is virologically suppressed. So you would imagine that if his caregiver has been giving him antiretroviral treatment, then she would also be giving him his TB treatment. So could this be something else? We would have access to cardiothoracic services where we would ask them to try and obtain tissue to give us a definitive diagnosis at this point.
Okay, so thankfully he fell into the sweet spot, and we managed to get him to see the cardiothoracics. So they did a bronchoscopy and an aspirate with a transbronchial biopsy. So his results on the gene expert from bronchial aspirate was a Mycobacterium TB that was resistant to rifampicin. The line probe assay had fluoroquinolone and aminoglycoside sensitivity, and the biopsy just showed neoplastic infiltrate, no neoplastic infiltrates were seen. So now you have this playful 2-year-old who's running around the ward with MDR TB.
Oh, God.
Jason.
You didn't mention in the bronchoscopy report, was there any endobronchial invasion or anything that required steroids, I guess is the question that I would ask.
So there was some erosion and there was compression.
Yeah. So I would start this child on second-line TB therapy along with steroids, and hopefully get him out of hospital. So he's not running around the ward.
So where would you put him? So where would you?
Where would I put him?
Yeah.
Do you have a room at the far end of the hallway? We assume that children that age are not infectious, but and certainly in my hospital we would never take them out of isolation, and we would keep him in isolation and take him lots of toys in his room.
Tabitha? So the one issue is that then, so once you put MDR on any script or in the hospital notes, every nurse in the hospital wants to know what should they do. So maybe we should answer that question. So every nurse as an infectious disease specialist, they've come to you to know what should they do now. And everyone's got some cousin or child who's also at home who's small.
Yeah, I will work up for all people who contact this patient, whether or not the sign of TB infection already, and maybe, but because the index case is MDR TB, so we may not have any specific prophylaxis for them.
So the one difficulty is
Yeah.
What is the prophylaxis for MDR TB? And what would you?
Oh, well.
No. Yeah, in my country, it just said, the guidelines said that if the index case is MDR TB, we just observe all in contact case, whether or not it's have the infection and progress to the disease and treatment when the disease develops. But we do not have any regimen for the prophylaxis for the contact case of MDR TB. I'm not sure about other setting.
So maybe from anyone else? So any ideas? So now you have a ward full of patients where this kid has been, who've been exposed to this child who's, so is there any protocol in your hospital for this specific intervention?
No.
No, I don't think so.
Yeah, we would probably try to reassure people of the non-infectiousness of a 2-year-old in terms of their ability to aerosolize. That we would keep them in their room in the event that they develop a cavity or cough up a hunk of their endobronchial TB. But I don't think we would advocate any sort of exposure protocol for an 18-month-old.
So I mean, one of the issues
except
just
in
to bring
the
up
OR.
is this lack of data and guidance around prophylaxis, specifically around children, for MDR TB, and the lack of appropriate formulations to give prophylaxis to young children, which is often a problem in our setting. So what we did was we had him on, put him onto MDR treatment. He was stable, and his air entry had improved on the left side. So he completed his MDR treatment. We had done quite extensive contact tracing, and we were unable to find identifiable source. And this is a picture of him, and this is what he thought of us when we stuck him in the isolation cubicle while we had him in the ward. So eventually he did well. He completed his MDR treatment, and he remained suppressed, and we had no further cases of MDR TB that we know of in the hospital. And I think that's our time. Okay.